Okay.
We're recording?
We are. Just make sure that it's
So I'm
doing
eating
its thing,
M&Ms.
as you should be.
Yes. Right, folks. So we're going to talk about back pain clinical guidelines. And this lecture is a bit of an odd one to pitch. And it's the first time I've delivered it in the format that it is in. And what I thought we'd do is talk about why we have them and what they're for a little bit. Talk about briefly the overall methods that most guidelines will take. Then I'm going to focus on the NICE guideline, which was published at the end of last year, which was a guideline produced in the UK. And I'm going to talk to you about that because I know more about it because I was on the guideline committee for that one. But we're going to talk about how guidelines agree on certain things to do with back pain and why guidelines might disagree, and they do, on certain things as well. And then what we should do with guidelines and whether they actually help people. And if they do, great. And if they don't, why not? And then at the end, there's going to be a little task for you guys to think about, well, if this is what guidelines say and we agree with it, how could we make it happen if it's not happening now in our local area? Before I start, there's a few things I have to do. One is to say some of these slides were developed by one of my colleagues on the guideline, and he's kindly allowed me to use them. That's Dr. Ian Bernstein. Now, the other thing is to say that while I'm talking through this stuff about the NICE guideline, I'm representing my views and not the views of NICE. Okay, good. This picture here behind me is a really beautiful infographic that was drawn up by the BMJ graphics team to summarize the guideline. And I've got a PDF of it that I'll put in one of the folders so people can have it, because it's a nice one-stop shop for the guideline if you want it. Steve's already told us, that we've got a big problem with back pain, that it's right up the list in terms of years lived with disability in the world, and that it's costing a fortune, both in those direct costs of care, but in the indirect costs of how it affects people in society. And the thing is, it's really hard to estimate what's happening to those costs, but there is simply no evidence that they're decreasing. And there's some evidence that projects that they might increase. A recent study from Australia projected that the costs are looking like they might increase. And this is a massive problem because what it speaks to is that we're not getting it right. We're not. We've got this big problem. And in the last 60, 70 years, we have thrown the kitchen sink at it in terms of clinical care. All these different disciplines are involved in back pain. You'll find a back pain expert everywhere. And we're treating more and more. But disability isn't changing. And it's right up there at the top of the list. That speaks to a problem, I think, of the widespread use of low-value treatments and potential over-treatment of back pain. But there's been guidance for back pain around for years. This is the first documented guidance for back pain. This is a genuine Egyptian papyrus, the Edwin Smith papyrus. He didn't write it, but he bought it off the guy who found it. And it is actually Egyptian physicians writing about the diagnosis and treatment of spinal injuries. And it's fascinating stuff. I've got a really great article that picks through the translation of it. It covers cord injury, and it covers all sorts of different injuries. But when it comes to the sort of back pain that we're talking about, these are the recommendations of the Edwin Smith papyrus. Examination. If thou examinest a man having a sprain of the vertebrae of his spinal column, thou should say to him, extend now your legs and contract them both. He contracts them both immediately because of the pain he causes in the vertebra of the spinal column in which he suffers. Diagnosis. Thou should say to him, one having a sprain in the vertebrae of his spinal column. And this is important. An ailment I can heal, right? Because unlike some of the other things covered in the papyrus, like spinal cord injury, these people get better, right? And these guys knew that. Treatment, and this is important because there might be some pearls for us in here. Thou should place him prostrate on his back, and that bit of papyrus is missing. So we don't know. We don't know, which is a crying shame, isn't it? But isn't that fascinating? Isn't that fascinating? It's not Mackenzie. No, it's not. It's not. The Greeks and Romans had some ideas about it. The Romans were particularly skeptical about what doctors could do, and this is a satirical piece. I love this. Sophocles Promising to set Diodorus's crooked back straight, piled 3 solid stones, each 4 feet square, on the hunchback's spine. He was crushed and died, but he has become straighter than a ruler. Awesome. And then coming up a bit more modern now, from 1636, the herbal or general history of plants, very much enlarged. That's not my title for it. And then we go down here and he's talking about the root of comfrey root. The slimy substance of the root made in a posset of ale and given to drink against the pain in the back, gotten by any violent motion, such as wrestling or overmuch use of women, doth in 4 or 5 days presently cure the pain. So there you go, comfrey root, if you've been overusing women, in 4 or 5 days will cure the pain, but benefits and risks. Although the involuntary flowing of the seed in man begotten, which sounds like a pretty profound adverse event. Okay. I would say that we didn't cover comfrey root in the nice guidance for low back pain. And then, I mean, I think those things are fascinating, and there's loads of historical documents like that tell us something. But, if you were a patient and you were in pain, you have back pain, and, you can't get an appointment with your GP, or, you haven't got an answer, the first thing you might do is consult Professor Google. So I did that, and I found all sorts of things that might help me with my back pain. The Bible cure for back pain, the 7-day back pain cure. I mean, if they really wanted to cash in on the evidence there, they should have called it the sort of 3 or 4 week back pain cure. Inversion tables, which probably won't cure your back, but might help you detach a retina. Herbal remedies, like putting rosemary sprigs on your back. Rosemary really should only be rubbed on a belly of pork. And my favorite, which is this subliminal CD, which you play in your Discman overnight. I imagine you can get it in MP3 format now. And it will play you messages, and your back pain will get better. So there's plenty out there for people. The market is full, and these are just the more unconventional things. A lot of what I'm going to talk about is based on a paper that Steve Camper made me write, which was kind of just summarizing some clinical guidelines for low back pain for a special edition in Best Practice and Research in Clinical Rheumatology, which is only really out in the last month or so. And the edition isn't officially out yet.
So around October, this should come out. So it'll be a special edition journal. It's 10 chapters all on back pain.
Our review is a narrative review, like those ones that I was slagging off yesterday. And the reason for that is because there's already a very recent systematic review of clinical guidelines for back pain that covers all of them by Wong. And again, I can give you the link to that. It's a good review. Okay. But what does a guideline group do then? When we think about developing clinical guidelines, what's the process of that? Well, before we do that, maybe, what do you think a clinical guideline is for? I mean, what is it? What's its purpose? About right. Okay, based on expert experience.
Well, experts put it together, and it should be based on evidence.
Yeah.
But that's not always the case.
Sure. So, I mean, it's interesting. Who should develop guidelines?
Who should be the people developing them?
Yeah, I mean, which organizations should develop guidelines?
I think it needs to be interdisciplinary. I'm not sure that I answered that question.
Why does it need to be interdisciplinary?
Because the problems we treat are complex, and it's like, hey, it's your muscles.
Yeah, I mean, that's certainly one reason. Any other reasons why it should be interdisciplinary? Do you know?
It's a conflict of interest.
Well, yeah, it would be. Absolutely. I mean, everyone has skin in the game, don't they? Anyone who treats back pain has a dog in the fight, and it's their market. And so if you have a unidisciplinary guideline, there's a huge vested interest in there. So if we're really interested in pathways of care for back pain and really looking at a sort of more global scale on how we should be managing back pain through the healthcare system, then we can't have unidisciplinary guidelines. You know, really interdisciplinary guidelines are where it should be. And should professional bodies, I mean, a professional body could recruit people from other disciplines and develop a guideline. Who might be a better source? What might be a better organization to do it in terms of conflicts of interest?
If you had a conflict reduced government body, that would be a good way to do it.
Right.
Not conflict.
Okay, so maybe a government organization. I mean, a government organization doesn't have that professional vested interest. Of course, they have their own vested interest, right? Healthcare costs a fortune. So you might be interested in reducing costs, and how that's balanced against delivering best practice might be a tension. But when we get an organization, so for instance, the NICE guideline, NICE is a government-funded organization in the UK that doesn't have any specific professional affiliation. It's funded via the National Health Service in order to really deliver information for the National Health Service in the UK. But when you're deciding on developing a guideline, the first thing that a guideline group will do is to identify and refine the subject and scope. So we already had a NICE guideline for back pain that was published in 2008. Actually, there were substantial problems with the implementation and uptake of that guideline, but it was there. NICE reviewed their guidelines periodically and decided that it was time, the time was ripe for an update. So they commissioned one of the groups they get to develop guidelines to start approaching people to develop a scope of the guideline. And scope's really important. What are we actually interested in when we're talking about, you know, how do we guide people into how best treat back pain? Are we talking about just non-specific back pain? Are we talking about back pain with specific pathology? Are we talking about back pain and leg pain or without leg pain? So you define the scope of what it is you want to look at. The next step is to convene and manage a guideline development group. So what you have to do then is find your experts. So you'll have a guideline manager. You will have a technical team of reviewers. So actually none of us on the guideline development group reviewed the evidence for the NICE guideline. There is a technical team, an army of systematic reviewers, in fact, employed by NICE, who did the reviews, which were then presented to the guideline development group to interpret, essentially. So you convene and manage a guideline development group. Of course, that could be quite challenging. Which experts should you choose? What NICE do is they recruit through a formal interview process. So they put out an advert for people who are interested, and they do it like you would for any other job. They then search and assess the evidence according to the scope and the protocols developed from the scope. They present that to a guideline development group over the guideline development period, who look at that evidence and argue about it and decide what it means and formulate that into recommendations, which are essentially declarative statements about different interventions and whether or not they should be used. And that goes to external review and consultation. Okay? And this is something that should happen really in all guidelines, is that stakeholders should be invited. Who are the stakeholders in back pain? Patients, absolutely. So patient groups, absolutely, stakeholders. Third-party payers, clinical special interest groups, professions. Anyone else? Commissioners? Well, third-party payer, in the UK, it would be, in the NHS, it would be care commissioners. But yeah, so a broad group of people, and any institution can apply to be a stakeholder in that process. And stakeholders get to comment on the development of the scope, and then get to comment on the actual draft of the guideline. So the guideline, our guideline was published, I think it was about May 2016 in draft form, the whole thing. And then you get all your stakeholders come back and submit comments, and so many comments. And then you come back as a group and then look to manage those and see whether and where the guideline might be revised. Okay. Now this really reflects the NICE process, but most guidelines will go through a similar process and will have similar checks and balances. In terms of convening and managing the GDG, you're going to want experts from each clinical discipline that has a regular role in managing people with back pain within your health system. But you're also going to want on that GDG another group of people again. Researchers were actually, I mean, we did have an epidemiologist on the guideline committee actually in this instance, a very good one. But who else? So we got epidemiologists, we had neurosurgeons, orthopedic surgeons, we had GPs, we had anesthesiologists, we had a physiotherapist, me. But who else should we have? We had 2 patients. And with the way that guideline group was set up, is one of the first things we were told when we first sat around the table is there was no hierarchy in the room, that everyone has an equal voice and should be heard and given an opportunity to speak. And that was something that was actually adhered to. And some people shout louder than others, but actually that was managed very well. Patients had a say on every decision, on every recommendation, which is pretty great. So we looked across, on the paper we wrote for best practice in clinical rheumatology, we took what at the time were 3 of the most up-to-date guidelines that had been considered to be high quality by recent systematic review. We had the US guideline, which was 2007-2009, the American Pain Society and the American College of Physicians guideline, which as we were writing this, most of that got updated. So we had to scramble to look at what the updates did and how that changed. We had the Canadian guideline from 2015. And even though it wasn't in that systematic review, we had our NICE guideline because we'd only just written it. No way we weren't going to have that. And we looked across the 3. The NICE guideline covers the UK except Scotland. Scotland have their own evidence commission called SIGN because of a lot of government is devolved to the Scottish Assembly. So we found when we looked across, where do guidelines agree on the recommendations that they give? Well, guidelines consistently recommend ruling out alternative diagnoses when a patient comes into you with back pain and offering high quality education, including the encouragement of an early return to activity. None of this stuff's going to surprise people. Right? So it's about making sure what's in front of you is a case of non-specific back pain and isn't some nasty or some other disease. So basic diagnostic triage that you guys all do, and then making sure that you deliver education that's of a high quality and encourages early return to activity, as opposed to bed rest and movement avoidance. Guidelines consistently recommend against the routine use of imaging for non-specific low back pain. There's not been a guideline published that recommended routine imaging for low back pain, but imaging rates are really high coming out of primary care, particularly in the US, but they're high. So that's something that's been around in every guideline that was pretty much ever published and yet isn't necessarily happening, which is quite remarkable. And the reasons for that, I think, are complex and interesting, and probably revolve around clinician belief, around incentives with regards payment, and around patients having a strong belief that these technologies will be able to pinpoint what their problem is. And I think in some ways in primary care in the UK, imaging is easier than not imaging at the end of a very long day with a very angry patient who's very demanding. And the problem is very similar to this idea of not prescribing antibiotics for the common cold. You know, we know that we're over prescribing antibiotics and they're not helpful, but it's actually very hard in the reality of the world for GPs to say, you're going to get better and I'm not going to prescribe you that antibiotic. I think there's a real parallel there. Guidelines consistently recommend physical exercise in some form for non-specific low back pain. Guidelines, or these 3 guidelines, consistently advocated a cautious approach to the use of opioids in non-specific low back pain. And we'll go into that into more detail in a bit. And all the guidelines in some form recommended that people should be aware of and consider psychosocial factors in the assessment and management. And that was reflected in either recommendations relating to the fact that these sort of factors are of importance, or recommendations related to interventions that incorporate strategies to address those factors. So these things are all consistent. I don't think anyone in the room would probably disagree with any of them. And I don't think they should be controversial, but it's an interesting question as to say, do we think this stuff, these recommendations are routinely being reflected in everyday care for low back pain? And if not, why not? And what are guidelines for? Of course, guidelines don't always agree And we were thinking about that. Well, why might guidelines disagree? Because actually, if you think about them, on the whole, they're reviewing the same evidence. Most guidelines are looking at effectiveness or efficacy questions. And so they're reviewing, on the whole, evidence from clinical trials or systematic reviews of clinical trials of interventions for back pain. So if they're doing that, really, they shouldn't differ too much. And so what are the different potential reasons why guidelines might differ? Well, one issue we found is whether a guideline prioritizes evidence of efficacy. So in this case, evidence that the intervention can outperform a credible placebo or sham, or evidence of effectiveness, i.e., does the intervention deliver benefits more than if you compare it to no treatment or usual care? In the NICE guideline, in the scope, we made the decision that where it was possible to control for placebo effects, where it's possible to deliver a credible placebo, we would prioritize evidence of efficacy first. We'd want to see evidence of efficacy before we saw evidence of effectiveness. Of course, that's controversial. It's open for debate, but that's the decision that we made. Other guidelines are quite happy to make decisions just on evidence of effectiveness, of the effectiveness of that treatment versus no treatment or usual care. A good example of this is acupuncture. So the NICE guidance recommends do not use acupuncture for back pain because there is a large body of evidence that shows that it doesn't deliver important benefits over and above sham. And there's very little uncertainty around that. The US guideline and the Canadian guideline consider the use of acupuncture. The US in a reasonably unqualified way, and the Canadian guideline specifies as an adjunct treatment for pain. And those recommendations are really based on comparisons versus usual care or waiting list controls. So the approach that's taken by the guideline is important and can affect the recommendations that come up. The date of publication is a key issue, because how up to date is your guideline? So the NICE guideline recommended do not use paracetamol for low back pain, largely based on a trial from Chris Williams, who we heard about earlier, which is a big trial in primary care in Sydney and shows absolutely no benefits over and above placebo. But our guideline was recent enough to pick that trial up. That trial dominates the evidence base for that intervention. And the other guidelines that we were considering, well, they came before, their searches came before that trial was published. So the scope of the guideline will have some influence. So for instance, does the guideline involve treatments for sciatica? Will decide whether they're making any recommendations for things like epidurals and things like that. But also, does the guideline include less conventional treatments like herbal remedies for pain? So we at NICE, we didn't do any reviewing of herbal remedies or things like that, but the American guideline and the Canadian guideline did review evidence for herbal medicines. Whether the size of effect is important is an issue. One of the recurring themes of the course here is that statistical significance isn't the same as clinical utility. I mean, we've said that over and over and over again. If we take p-values as our arbiter of effectiveness, then that's a lower bar than if we take some form of minimal clinically important difference. But of course, as we said the other day, MKIDs for pain are a bit of a vexed question. At NICE, we actually, probably for the first 3 meetings, we debated what an MCID should be for the between-group difference. And in the end, we settled for a 1-point change on a 0 to 10 pain scale, which is pretty low, but it's consistent with the OMERACT recommendations that we talked about the other day. It's a low bar, but it still shifts our attention away from the p-value. The US guidelines are largely based on statistical significance for effectiveness, and that will impact on recommendations. So for instance, opioids for chronic low back pain. Opioids deliver statistically significant benefits over and above placebo, but they don't deliver, in our analysis, in our meta-analysis of studies, a 1-point change on a 0 to 10 pain scale, which actually really surprised me, but that's where it was. Now, when you package that up against the known risks and harms of opioids, after some discussion, the GGG for NICE decided that do not routinely use opioids do not use opioids for chronic back pain was the appropriate response. Had we gone for statistical significance as our main arbiter of effect size, of effectiveness, then we would have come possibly to a different decision. And then there's interpretive differences. Each guideline group's got different people on it, and those different people will interpret things differently. Now, actually, it's really hard to have interpretive differences where you've got nice, clear answers with very little uncertainty. But that's something we don't see very much in back pain research. In back pain research, we have generally loads of uncertainty. And the more uncertainty there is, the more scope there is for interpretive differences between guidelines and guideline groups. I like to think, to some extent, if you have an intervention that is inconsistently recommended across guidelines, and you're happy that the guidelines took a reasonable approach, that should give that intervention a bit of a buyer beware label. That evidence is uncertain and inconsistent. That's an index of that. So we're going to move on now, and I'm just going to take you through what we did recommend in the NICE guidance for low back pain. So our definition of low back pain was your classic real definition of non-specific or mechanical low back pain. Back pain not due to a specific cause, not due to structural problems, not due to inflammatory conditions or neurological disorders or serious spinal pathology. I mean, we're all pretty familiar with what we're talking about when we talk about non-specific back pain. Once the scope was approved, the job was massive. But luckily, we didn't have to do it. They had this technical team of reviewers to do it. All we had to do as a guideline development group was come to NICE every month for a full day meeting, having spent a week before reading through these 600-page documents of evidence with thousands of forest plots in. But we had 23 overall review questions, which we could answer through 22 individual de novo systematic reviews. Now, NICE methodology took the decision to do original reviews of trials and not include existing systematic reviews or Cochrane reviews, which I found an interesting and slightly inefficient way of going about things. The American guidelines review systematic reviews and then go and look for further trials. The Canadian guidelines reviewed existing guidelines and then look for more recent systematic reviews. So all these guideline development groups are taking a subtly different approach to get into the evidence. But NICE started from scratch. So we had 23 review questions, 22 systematic reviews. Overall, Ian, our GP, counted that they'd screened 43,000 records and reviewed 734 papers. We received 720 comments from registered stakeholders and 297 comments from editors and reviewers within NICE. It took 3 years to produce the final guideline, which in all of its glory runs to 3,600 pages. And we made 41 individual recommendations and 7 research recommendations. And the reason I show you this is because, you know, we talked about how do you do evidence-based practice as a clinician? And I want to know about, what the best way is to manage back pain. It's an enormous job. And that's what guidelines are hoping to do, is to try and do it so that clinicians have these tools that they can say, I know the audit trail, I know how it was done. And so, because you can't do that. I mean, none of us can do anything like that. Even if you took an individual intervention, it's a pretty vast job. Okay, so language is important in recommendations. And NICE have a framework for the language you can use when you're making a recommendation. So let me talk you through it, because it's very basic, but it leads to interesting conversations. You can say, no recommendation. It's just too uncertain. There's nothing out there. We're not going to make a recommendation either way for this intervention, which throws up an interesting question. Where does the burden of proof lie for an intervention? If people want to do an intervention on the basis of no evidence that NICE can judge, should we make no recommendation? Or should we say, well, do not use, go forth, get your evidence. When we update the guideline, maybe we'll make a recommendation. Yeah? Do not use. That's a declarative statement. Do not use. Not don't use it sometimes. Try not to use it. Do not use. Now, guidelines are not mandated. They're guidelines. But this guideline is saying, we think, do not use. Do not routinely use. Now we're getting into interestingly nuanced language. So, when you're saying do not use, if you think about the political ramifications of saying do not use an intervention, they're pretty massive. And also implications for the process of care. So do not routinely use is another option that people can use, but it's a dangerous option for a guideline development group because language is important. If we put a do not routinely use thing out there, then it's very easily abused. Well, none of my patients are routine. That wasn't routine use. I used it for a very specific reason. If we're going as a group down the do not routinely use path, it's because we have real concerns that this isn't a valuable treatment or the benefits don't outweigh the harms. But maybe there's a bit of uncertainty, or maybe there might be some evidence pertaining to specific groups of people. There was a few times where the do not routinely use option came up, and the question then became, well, when would you not routinely use it? Tell me the circumstances and show me the evidence for that, which is another really interesting conversation to have. One of the things I learned as a physio who does systematic reviews is it's one thing to get the evidence in front of you. It's another thing to turn that into a recommendation that's defensible and meaningful. And then it's hard, it's nuanced. Then there's consider. So consider is where, on the whole, we think the body of evidence is positive and that this treatment is likely to deliver benefit, but we're not sure. There's some uncertainty, and that uncertainty could be due to risk of bias. It could be due to imprecision. We used grade. You remember the grade system for judging the quality of a body of evidence? So it might be a low grade rating, or those things will be reflected in a low grade rating. And then at the top of the tree, the one you want, because we all want to say nice things, is offer this treatment. And that's a declare, that's a statement. You should offer this treatment to someone with back pain. And here's the thing, of every intervention and all those reviews, the only thing we said offer for was good information about self-management and supporting self-management through the pathway. And the interesting thing about that is it's not based on very much evidence, but as a group, could you imagine not doing that? Give your patient good information about the condition and what we think is the best advice for self-management. So that's not a strongly evidence-based recommendation, and we write that very clearly in the guideline. It's a recommendation based a lot on expert consensus. There were no people that were not in consensus that we should be offering people the best information we can about back pain. Actually, I saw, and I haven't read it yet, there's a systematic review about self-management strategies and what should go into them. And it says, I read the abstract, so I haven't read the review, I don't know if it's any good, but it's that common story that actually the evidence underpinning what we think is best information for self-management isn't very good. Steve?
There's also a chapter in the upcoming best practice.
There you go. So
self-management and behaviour change.
I look forward to reading that. But yeah, I mean, this stuff isn't clear cut. Yeah. It's not clear cut. But the alternative is to say, don't give people good information about their condition and advice to self-management. The whole guideline, like I say, is drawn on this infographic, which I'd love to be able to use and animate in my slides, but I can't, so I did my own. And this is the guideline just represented a different way. So you've got a person age 16 or over with low back pain with or without sciatica. If they've got red flags, or if you suspect that they don't have back pain, non-specific back pain, they're out of the pathway. They're no longer part of this guideline. There's other things to do with those. And the first section here, you see the red triangle? Every so often a red triangle is going to pop up because I presented this similar stuff to some clinicians in the UK recently. And the red triangle pops up when I think there might be an interesting question about implementation of the guideline for you guys to consider, which might help inform the task that we do otherwise. So look out for the red triangles, you can't miss them. So we're going to start off with the first section of the guideline, which is to offer information and advice to support self-management. We've also got risk stratification in there too. So this is kind of the assessment part of the pathway. Think about alternative diagnosis, we've already covered that. Exclude specific causes, we've covered that. Do not routinely offer imaging in a non-specialist setting. And we went a bit further and suggested that we should explain to people with low back pain and or sciatica that if they're being referred for a specialist opinion, that doesn't mean they're being referred for imaging. It means they're being referred for a specialist opinion and they may or may not need imaging. And we suggested that even in a specialist setting, which isn't a GP practice, but could be a musculoskeletal interface clinic, we have these things in the UK now, where it's like a halfway clinic between primary care and secondary care is an interface clinic where you'll be seen by a musculoskeletal specialist much more quickly than you would be in a specialist clinic. And that's normally an extended scope physiotherapist. And there's a big push to get more extended scope physios into primary care to reduce the burden on GPs, because there's an argument that they might be more efficient at this sort of triage process. It's political. We suggested that you should only really consider imaging in specialist settings of care for people with low back pain if the result is likely to change their management. So, you know, we know that these things aren't diagnostically awfully useful. So even if you're into secondary care, there's only really a good case for doing imaging if you're considering an epidural, or if you're considering spinal decompression of a specific nerve root, just to confirm the level. Or, and we, interestingly, and we're going to talk about radio frequency denervation a bit later because it's become really complicated, but that is actually on our guideline. We don't recommend you image prior to doing radio frequency denervation because imaging findings really don't give us any good index of suspicion for facet joint involvement. Okay, so here's some issues for potential implementation. How can we discourage unnecessary imaging? This stuff is known. We shouldn't be doing it. And we've known that we shouldn't be doing it for a long time. So how do we make that happen? And how can we better manage patient demand? So, you know, we can manage the clinician end through education, and it may not work, but we, you know, there are potential strategies that we can do there. But it's not just about the clinicians. Somehow we need to manage patient demand. There are more than one lever that's driving unnecessary imaging, and we need to think hard about what those levers are. Risk stratification. So we suggested that you should consider, it's not an offer, consider using risk stratification. For example, the Start Back risk assessment tool at the first point of contact to inform shared decision-making about management. You guys are familiar with Start Back, yeah? We talked about it yesterday. So Start Back is a brief questionnaire that stratifies people by their risk of really a poor outcome. So you'd be in a low risk group, a medium risk group, and a high risk group. Now that's a risk stratification tool that in an RCT has been shown to deliver benefit over not using the tool, although there was a follow-up implementation study that found it much harder to do it. So this is complicated stuff. And there is uncertainty around the benefits of risk stratification. But one of the messages I think of Start Back is that not everyone needs referral for complicated care. And we could be better at working out who we refer for more complicated care. And if we take the Start Back trial as an example, that may improve outcomes. And one of the really interesting things about the Start Back intervention is those randomized into in the low risk group rather. And the low risk group received one-off session of good quality education and advice on self-management, things like that. That's all they got. They didn't do any worse than the guys in the low risk group who were referred off routinely for care. And then, you know, what we're learning there is, you know, you don't need to treat everyone, you know, with great, but that doesn't mean people in the low risk group can go to their GP and he say, oh, you'll be fine, don't come back. Because that's not what they got in that trial. They got high quality educational session. So we need to work out, if we are going to say to the low risk people, you only need a simple, or we know, we think you only need a simple low intensity intervention. It can't just be the GP saying you're fine, because that's not what the evidence is based on. That would be a misinterpretation. So based on risk stratification, consider simpler and less intensive support for people likely to improve quickly and have a good outcome. For example, reassurance, advice to keep active, guidance on self-management, or more complex and intensive support for people at higher risk of a poor outcome. So in the Start Back study, guys in the medium risk group basically got physio, multimodal physio. And the guys in the high risk group got a really psychologically informed multimodal physio, and those physios had been trained to deliver aspects of CBT and those sorts of principles and really throw that in there as well. So kind of psychologically informed rehabilitation. Now, we haven't taken the Start Back interventions and said these are the things you could do, because we think that would be an overinterpretation of an individual trial. We're also not mandating risk stratification. I suspect that a lot of very good tuned in clinicians risk stratify anyway, But I suspect that isn't something that routinely happens in primary care, that really, elegant judgments about what this patient might need are being routinely made. So it's trying to bring some consistency to the process. You guys know the start back tool because Steve showed it to us yesterday. And so you get your score and it decides on the group. The other bit of interesting language we used is to inform shared decision making. It's not to dictate the intervention that that patient gets, right? It's about having a conversation. So then if we're going to agree with that as a recommendation, how can we facilitate risk stratification? In the start back trial, physios did the risk stratification and they did it. In the impact trial, GPs did the risk stratification. And one of the things they found was it was really hard to get GPs to go through the process and use the tool effectively. So that's an issue. How can we make that easier? I mean, you might put it onto the GP computer system as something that they have to fill in, or there might be any number of ways, but certainly talking to people who ran the start back trial, they think that they learned quite a lot from the problems they had getting people to be able to apply it. Self-management then. What is self-management for low back pain? Provide people with advice and information tailored to their needs and capabilities to help them self-manage their low back pain. And we've already talked about this isn't strongly evidence-based. A lot of this is driven by the consensus of the professionals and the GDG. Okay? The benign nature of the condition, the reasonably good probability of a rapid improvement in symptoms, the importance of early return to normal life activities, including return to work where applicable, and the value in engaging in physical activity. Were the components that we came up with, whereas they might not be your favorite components. And we can't say for sure that this is exactly what self-management should look like. Right? But these were our recommendations based on consensus. How do we ensure the consistent delivery of high quality information? How do we ensure that different clinicians that people with back pain come into contact with are being consistent in the information that patients are getting? I think that's a massive challenge for the industry. How do we do it? So now we come on to sort of non-invasive, non-pharmacological interventions. And this is what we decided we might offer people. So consider offering exercise in a group, because what we found was, you can't say that individualized exercise programs are better than group exercise programs. And if we're considering efficiency and cost in there, then we felt that it would be reasonable to suggest that exercise in a group would be a better thing for the NHS. And there was no evidence to suggest that on the whole, it would be a worse thing for patients. And we wouldn't make any recommendations on what type of exercise that should be, because you can't. There's no clear evidence that one type of exercise is better than another. So the way we divvied up exercise was biomechanical, core stability stuff and strengthening stuff, aerobic, your more cardiovascular kind of training, and mind body, which has got your Tai Chi and your yoga and your Qigong and all of that stuff in there. But none of them win the race. But exercise delivers small benefits, but not necessarily, but consistently across the evidence base, enough to meet the minimal clinically important difference. Manual therapy you might use as part of a treatment package that includes exercise. Psychological therapies you might use, or psychological strategies, as part of a treatment package that includes exercise. And what we're driving at here is the evidence for manual therapy as a unimodal intervention isn't good. The evidence for psychological therapies, which always surprises me, for back pain as a sole intervention, really isn't good. There is some, albeit uncertain, evidence that multimodal interventions, so UK Beam showed that exercise plus manual therapy was the better of the interventions that they looked at, with some education with a CBT sort of based theory. And there was a few trials that were suggesting that multimodal might be better. That's uncertain. So we didn't want to recommend manual therapy or psychological therapies as a sole treatment, but maybe as part of a treatment package, including exercise. This is really not prescriptive. If you think about this, there's lots of freedom for you as a clinician to tailor and interpret what you actually deliver to the patient. So we've covered that. And then we also recommended you might consider combined physical and psychological rehab programs. So these are the much more strong psychological component to them. So that would include the MBR stuff that Steve was talking about yesterday. But there's some emerging evidence now that it might not necessarily need to be multidisciplinary, that actually what we're looking at is rehab programs that consider the complex pain patient from multiple perspectives, from a physical rehabilitation perspective, from psychological perspective as well. So that could be a really intense MBR program. I guess within that, you might lump in things like cognitive functional therapy. There's a few different approaches, okay? So where previous treatments haven't been effective, it may be, or where a patient's at very high risk of a poor outcome on the start back, it may be that something much more psychologically informed and perhaps more intensive might be indicated. And always promote and facilitate return to work or normal activities of daily living. This should be something that's consistently done. So can we offer rehab services that offer group exercise as well as one-to-one care? And then can we make group exercise appealing to people? Because I can imagine that people wanting that one-on-one care may be a barrier to uptake and acceptability of group exercise. How can we ensure that the workforce delivering rehab actually have the skills to effectively manage psychosocial problems? This is a biggie in physiotherapy at the moment. There's some pretty good evidence out there that everyone on paper buys into the biopsychosocial model. But when you observe what they do, it tends to be much more bio. And when you ask them how confident they feel, they actually don't necessarily feel they have the competencies to deliver psychological therapies to fidelity. And so we need to look at undergraduate programs and postgraduate programs to see if we're really adequately addressing those. We need to consider how can we upskill people if we're not going to go down a multidisciplinary route in order to deliver those things better. And who can deliver combined psychological and physical programs, and can we match the demand? So Steve yesterday was talking about, we've got this program, we've got evidence that says it might be helpful. In the UK, if you want to go to a chronic pain management program, then I'll sit you on a waiting list and we'll see you in 2 years often. And it will depend entirely on what your postcode is, where you live and in what health region you're in. So how can we upscale our ability to deliver combined psychological and physical programs? Do not offers. Now we're going to go through the things that we said do not offer. Manual therapy is a sole intervention. Psychological treatments is a sole intervention. Acupuncture on the basis that it wasn't better than sham. Orthotics, belts, corsets, rocker sole shoes. And a colleague of mine who I worked with at Brunel did the trial on rocker sole shoes versus just normal flat shoes and found actually that there was no effect. But if you wanted to look at a direction of trend, flat shoes were looking a little bit better. Traction, no surprises there, I would have thought. Electrotherapies, pens, TENS, interferential, therapeutic ultrasound. So in terms of implementation, how do you facilitate the de-adoption of those approaches? And that will be, the scale of that challenge will be different in different countries. But, if we want to do better at the things that we think do work, we need to make space for them, I think, as well. Every treatment, ineffective treatment, isn't just ineffective. It's harmful in a way because it's an opportunity cost. You're doing that when you could be doing something else. And if we do have options that we think have a higher probability of doing some good, then we need to make space for those options. Pharmacological treatments now. We recommended considering oral non-steroidals because in our meta-analysis, we had a clinically important effect. Now, interestingly, a couple of systematic reviews have come out recently that suggest that the effect size falls beneath our MID. So what that tells us, I think, is that the effect is somewhere near the MID, but whether it meets it isn't robust to different ways of synthesizing the data. So there's definitely uncertainty there. But we said consider oral non-steroidals, not offer, consider. Right? Take into account potential differences in gastrointestinal, liver, cardiorenal toxicity, individual risk factors, including age, and always think about ongoing monitoring of it, take them off it if they don't need it, ongoing monitoring of risk factors, consider the use of gastroprotective treatment, and consider the lowest effective dose for the shortest possible period of time. Because obviously, all the time you're on a non-steroidal, you're accumulating risk. Consider weak opioids. with or without paracetamol, for managing acute back pain, only if an NSAID is contraindicated, not tolerated, or has been ineffective. Now, that's not a strongly evidence-based recommendation. But at the point towards the end of the guideline we got to, the only drug option that we were making available with some confidence was non-steroidals. And lots of people can't or shouldn't take non-steroidals or can't tolerate them. So that was a pragmatic decision, essentially not to leave clinicians with nothing to offer, particularly because we didn't have strong evidence of ineffectiveness. But you can see how hard it is to do this. That is a judgment. It's a judgment, and it should be considered as such. We haven't clouded over that. If you read the section where we link the evidence to recommendations, we're very clear that that is a judgment of the panel. Do not offer paracetamol. Do not offer opioids, with that caveat that we've just talked about. And the reason being, in acute back pain, there's a lack of evidence for clinical cost effectiveness. A consensus view that alternative was needed where NSAIDs could not be used or were not effective, and a research recommendation for future research. And don't use in chronic low back pain because of the potential harms of adverse events, and this acknowledgement of this global problem of opioid use outweighs the very small benefits. Do not use antidepressants for back pain, amitriptyline, SSRIs, SNRIs for back pain, because the evidence that we had suggested no clinically important difference compared to placebo. So implementation-wise, how do you reduce prescribing of opioids and other ineffective drugs for chronic low back pain? Interestingly, anecdotally now, a lot of the docs are saying, well, you know, people aren't prescribing opioids as much. Well, I've got 100 patients coming in on gabapentin that's not helping, or pregabalin. So if you're not going to use that, we'll use something else. Those drugs aren't recommended for back pain. And we're talking specifically about back pain, not leg pain here. So how do we do that? How do we go about reducing prescribing? That's a massive challenge. Additional specific treatments for sciatica. So this is the sciatica-specific aspect of the pathway. Basically, offer non-invasive treatments that we've recommended for back pain. So everything I've said for back pain in terms of non-invasive, non-pharmacological treatments, you might offer. And the timing of additional management options really depends on the clinical circumstances. We suggested offer epidural steroids with local anesthetic for acute severe sciatica. Now, the picture with sciatica is much like the picture for back pain. People get better on the whole. But sciatica is god awful, and people often suffer a great deal. And some people might not want to wait for it to get better. And there is some evidence that epidural steroid with local anesthetic can be helpful. Okay? But we didn't recommend it be used for claudicant leg pain due to central spinal cord canal stenosis, because there was insufficient evidence for that group. Consider spinal decompression for people with sciatica when non-surgical treatment has not improved, where their radiological findings are consistent with their symptoms. And here's another thing. We had a review on whether there were factors that might mean that you don't want to proceed with invasive treatments for people, and essentially found no evidence that was usable or meaningful. So our recommendation was not to allow a person's BMI, their smoking status, or the psychological level of distress to influence the decision to refer them for a surgical opinion, because that wouldn't be an evidence-based decision. So essentially it's discriminatory to do that. And then there's neuropathic pain medication for neuropathic sciatic pain, but we didn't review that evidence. NICE have another guideline for neuropathic pain, although it's not specific to sciatica. And this gets a bit messy. So the NICE guideline for neuropathic pain suggests you offer a choice of amitriptyline, duloxetine, gabapentin, or pregabalin as an initial treatment. If not effective or not tolerated, offer one of the remaining 3 drugs and consider switching again if the second is not, or the third drug tried also not effective and not tolerated. Consider tramadol only if acute rescue therapy is needed. Consider capsaicin cream for people with localized neuropathic pain, which isn't sciatica, of course. There'd be a lot of capsaicin cream for sciatica. But this is interesting because we didn't review this data. Now, you might be familiar that some of Steve's colleagues have just published a trial of pregabalin for sciatica against placebo, and it showed no effect. So that's an interesting challenge to the guidance that we're relying on. We're not always going to get it right, and the evidence base evolves. NICE will review the guidelines every few years and decide whether there is scope for a meaningful update. So, and this guideline was published in 2013, so 3 years before ours. And then we come to radio frequency denervation. You guys are familiar with that, yes? So putting a thermode into the medial branch nerve and essentially denervating it in order to stop nociceptive drive, because we hypothesize that the facet joint is the source of pain or structures supplied by that nerve. And there was some evidence that radio frequency denervation was effective versus sham radio frequency denervation for chronic low back pain. And I have to talk about this very carefully at this point. So the recommendation from the guideline was to consider it when other treatment options have not worked for them, when there is a reasonable clinical index of suspicion that the pain is thought to come from structure supplied by the medial branch nerve. Now, this is funny because Martin Underwood's group recently had a consensus statement about what facet joint pain might look like in order to inform a trial of facet joint injections, which has since been discontinued because they couldn't recruit anyone to it. But they came up with the sorts of things that we might have been taught, really, i.e. localized pain, predictable mechanical pattern, particularly on sort of closing down movements, unilateral. These are the things that raise the index of suspicion. The reason we've got this in there isn't because there's great evidence that that's a diagnostic test for that. But if you start saying consider radio frequency denervation when other treatments haven't worked, then you could end up pushing an enormous number of people at a population level through that invasive procedure. And even the radio frequency denervators would suggest that one needs to be more specific, more discerning than that. Consider it where there are moderate or severe levels of pain, 5 or more on a VAS. Only perform it if a patient has a positive response to a medial branch diagnostic block, and do not offer imaging for people with low back pain as a prerequisite to radio frequency. So the implementation issue was, how could we ensure, if we're going to do this, properly targeted referral and avoid this flood of people that won't benefit from it? Sarah. Oh, she's there, look, she's back in the room. Who won't benefit from it. How can we get that? But there's another concern. There's another concern. It's a much bigger one. And that is 2 weeks ago in, it was either JAMA or New England Journal of Medicine, was published a trial of radio frequency denervation versus usual care for back pain and showed no effect. So now that's a conversation that has to be had with the guideline group. That's a conversation that needs to be had whether NICE decide that that is a level of evidence that is going to make them look again at that decision. And as I'm aware of it, that isn't a process that's occurred yet. But that's an interesting challenge. What I think at the moment is you should look at the trial yourself. It's definitely a source of substantial uncertainty around the utility of that recommendation, he said, being very careful and political. Do not use spinal injections for low back pain. Don't do facet joint injections. Don't do medial branch blocks as a treatment technique. Don't use intradiscal therapies, prolotherapy, trigger point injections, Botox injections, epidural steroids for back pain, not sciatica. Do not use spinal fusion for low back pain unless it's as part of an RCT. And that is because spinal fusion is common. It's less common in the UK than it is here for back pain. There is evidence that spinal fusion has similar effects to multidisciplinary biopsychosocial rehabilitation, and that spinal fusion does deliver something approaching an MID, but the evidence is really weak, and the risk of adverse events, even in those small trials, is actually pretty high. And we're talking about potentially very substantial adverse events. So our view was that given the cost and the risks of the technique, and remember our GDG involves surgeons too, our view was that to continue doing spinal fusion for back pain, we need better evidence to justify it. So it's an interesting recommendation. It's a bit of a fudge. It isn't that there's no evidence that spinal fusion might benefit people. It's just that the evidence is really not clear and there are risks and costs, and we think we need better evidence. So there we are. And do not use lumbar disc replacement because it doesn't seem to be better than spinal fusion, but the limited data we have is that it's more risky. An interesting expert judgment from the surgical experts on there is the thing about disc replacement is that it often needs revision, and the revision is the really risky procedure because of all the scar tissue that's come around there, and you often get adhesion of vascular structures and you can cause big bleeds. Even in small trials, there were issues like limb loss, post complications. Limb loss, yeah. So the point is there that lumbar disc replacement is an innovative procedure that doesn't outperform fusion, which we're not convinced by, but may confer greater risks and is more costly. So how do we facilitate the de-adoption of all these spinal injections and surgery for non-specific low back pain? We didn't make recommendations of what a clinical examination could look like because there's really not any good evidence that would guide us. We didn't make recommendations on postural therapies. There's one sizable trial of Alexander technique, but we had uncertainty about the effectiveness, particularly with regards to what they compared Alexander technique to. There's conflicting evidence for laser therapy, and there's only one trial of antibiotics out there, which is quite a controversial trial for a number of reasons. Sorry? Oh man, now you're asking. I can't remember. It was high dose and intense and sustained antibiotic therapy. I can't remember the actual drug. So the question then is, how do you do it? We've got a guideline. So how do we make people do it? Because what's the point of a guideline that no one actually acts on or reads? And Fisher wrote a sort of position paper on that and suggested, you know, you've got to disseminate it. And that's more than publishing it. You've got to get out there and tell people about it and explain it and have conversations about it. You've got to educate and train people to be able to deliver these things as well. It's not, shouldn't just assume that the existing clinical community can do that. You need to engage things like key opinion leaders. This is learning from drug companies. Drug companies engage that, key opinion leaders to go out there and promote their products. Well, guideline committees, these guys suggest, should be doing the same and getting prominent people to go out there and promote that. I haven't seen whether that's happening. You might start employing decision support systems, like, in a GP office, if he wants to prescribe an opioid for back pain, you could have a little box that flashes up and says, "You sure?" Or imaging. You can build the start back tool into it. As soon as the GP puts down back pain, it pops up and they have to complete it before they continue. There's lots of nudges that could be used, and you just have to think innovatively how that happens. Of course, you can mandate it. When I went into it, halfway through, it occurred to me that I've always been frustrated that we don't seem to be able to do evidence-based practice. And I wondered whether we'd achieve more through evidence-based policy. That, NICE guideline is there to help commissioners make decisions. And there is definite evidence around London now that commissioners are decommissioning a lot of the treatments that we say do not use. And that will make people stop doing it because their service won't receive any money for it. But clinical guidelines are not instruction booklets. They're not mandatory. They become mandatory when policymakers use them to inform policy. What are the barriers for people actually doing guidelines? So there's a number of really nice papers about why people do or don't listen to guidelines. And Fisher characterized them into personal factors, guideline factors, and external factors. So with personal factors, the sheer volume of clinical guidelines out there, particularly for GPs, is enormous. And keeping abreast of them is really, really hard. So imagine that you can't keep abreast of all the evidence, but when you're a generalist, you can't even keep abreast of all the guidelines. There's a general lack of knowledge, not only of what the guidelines say and where they are, but also how they're made and why they're not, and why they might be reasonable things for you to pay attention to. There is a widespread across many clinical communities rejection of the evidence-based practice paradigm. The I know best and the evidence doesn't reflect my practice kind of view. A recent study of osteopaths relating to the 2008 guideline was titled Quiet Dissent. And they concluded, after talking to osteopaths about why they weren't conforming to guideline recommendations, that they had an evidence-based pyramid that had been turned on its head. So you've got trials and systematic reviews at the bottom and personal expertise and opinion at the top. And the other thing, we're talking about clinicians, but again, it comes back to, well, are these guidelines acceptable to patients? We've got this issue of imaging, for instance, but a review of patients' thoughts about OA guidelines were that many patients thought that physiotherapy would make them worse and exercise would be damaging. So there's that. Guideline factors. are these recommendations feasible? Are they credible? Has the guideline been delivered with enough consultation to be acceptable to people? Now, that's really challenging because you don't make your guideline, you might make it more acceptable by telling everyone they can keep doing what they're doing. But that isn't credibility in its truest sense. And is the guideline accessible? Can people access it and interpret it? And then external factors are kind of local organisation of healthcare resources and buy-in from multiple members of the multidisciplinary community. In terms of future directions and sort of controversies that arose when we were thinking about guidelines, we've already touched on this one, the burden of proof. People are reluctant to start taking treatments away that are out there in the absence of really strong evidence that they're harmful or work. If there's uncertainty about their benefits, people don't want to take them away. They just want to keep doing them. But where is the burden of proof? And how did we get to a position where we routinely deliver treatments and there's no evidence of effectiveness? That's an interesting question, I think, for people to engage with. How do we weigh up benefits and harms? Most guidelines look very systematically for benefits, but don't look systematically for harm. They'll get harms from the RCTs they included, but RCTs are really bad at telling us whether treatments are risky or harmful because they're not big enough. A lot of important, severe and significant adverse events are rare events, and you won't pick them up. You might pick them up through registry data. You might pick them up from big cohort data or big health databases. And things like the yellow card system, which is a very impartial system, for it's an incomplete system for monitoring drug safety. Systematic reviewers are really wrestling still with what is a good way of systematically reviewing harm, because the evidence base for getting to the information is a complete mess. At NICE, we took no systematic approach, and to my knowledge, nor is any other guideline. But I think that's a problem. I think we don't do it because it's hard and it has massive resource implications. But I think we're missing something that could be potentially important. We tend to look at discrete interventions and look less at process of care. And there's not a lot of evidence about process of care. Process of care issues might be related to things like the Get PT First campaign. Right? And there was some observational evidence that people who went to a PT early with back pain might do better and use less other resources. But when they took that to an RCT, they didn't find that was the case. But we could probably use better studies of how care is delivered in terms of the process. And then, all of this stuff we want to do, we think we know what we want to be telling patients. We think we know how we want to be biased in our care. But how do we get people on board against all the misinformation that's out there? I mean, everyone who follows Mary O'Keefe, she's on a one-woman mission, it seems to me, to try and bust some myths. But the point about that is, we do have some evidence. Rochelle Bookbinder did a landmark trial in Australia where they did this really amazing multimedia approach to educating GPs and the population. They got celebrities and sports people to really bust some of those myths, and it changed healthcare utilization, behavior and beliefs. Other studies have tried similar things and found no effect, often though at a much lower dose. They haven't spent as much money on it. I don't think that question's been answered, and I still think there is a lot of interesting stuff to ask about how we change people's perceptions of what we should do with back pain. So then the question is, now what? People often see guidelines as a threat. I've been through the process now from one side of it. And so it's really hard to do, but I'm less cynical about the process than I was going in, because I recognize what drove how we came up with the product. And, you can make what you will of it, but this is what we came up with. And, what we're doing is we're navigating uncertainty. We're not just finding the truth and saying wicked. We're trying to navigate substantial uncertainty to come up with good decisions for people. And that's not an easy thing to do, he said, defending himself. So that's the lecture on guidelines. So it's lunchtime, so maybe we should have lunch. Is it not here? Alternatively, what we're going to get you to do either before or after lunch, but probably after, is this. I want you guys to think about the NICE pathway, just because that's the one we've talked about today. Pick an element of the pathway you think is a good element that would improve care here in Chicago. Think about elements of it that don't happen consistently in Chicago. Prioritize one and consider how you would do it. How could it be implemented? What are the barriers? What could facilitate it? How would you measure or evaluate whether it happened? That's the goal. I'll leave that up, actually.
Leave the homework up. For you from Corey, he said, he's been on for just a couple minutes, but he's already disappointed in the lack of predator references.
They were on day one.
And he's hoping that at some point he'll throw in an occasional, not sure how he's
Get to the chopper.
Come on, I'll do my best.
I said, I'll pass it along, perhaps you'll see it on the recording.
So, tell him I ain't got time to bleed.
He's I actually saw that movie, so I know.
I'll tell everyone's flagging now, I can sense it.
No, this is good.
I'm tired.
It's good. Stop the recording when he's done.
Hi, everyone. This is me figuring out how to stop the recording. Maybe. Hopefully Sarah edits these. Not the same screen.
Whole development or the like which part of the
In terms of the workshop, I think it's more like these are the recommendations for what care might. Sure. So thinking about what happens locally. Where does that not happen locally? And then what would it take to try and make it happen? Because this is the great thing about guidelines. We all recognise we write them. So implementation, kind of quality improvement was really high on the agenda in the UK. But we still, I don't think I necessarily know how we should do it. So it's interesting to try and do it.
How do I turn the recording off? It still says it's recording, but I don't see how to turn the recording off.
Come here.
Oh. And so I am. It's like I don't want to kill it.